Our special subject for today is update on adverse effects of oral anti-diabetic agents. Not all bad, but physicians should be cautious. Now, it's interesting. I keep encountering coincidences almost every day in my life. I decided on this subject yesterday. Last night, I got the current issue of the Journal of the American Medical Association, and their feature article is entitled, Comparison of Clinical Outcomes and Adverse Events Associated with Glucose-Lowering Drugs in Patients with Type 2 Diabetes. Here's the article. Now, it's very interesting that the conclusions of this Cochrane survey of hundreds of studies of oral anti-diabetic agents were that and they compared them mostly to Metformin, which was sort of a gold standard. And their comparison was that adverse effects were minimal and almost not different from Metformin for just about everything. My experience does not quite jibe with this, and what I'm going to talk about is my experience. I'm going to go down each of the oral agents that are used to treat type diabetes. The first one is a class called alpha-glucosidase inhibitors. This includes acarbose, glycet, and other similar products which are intended to inhibit the digestion of simple polysaccharides, that is, sugars that are not pure simple sugars like glucose or fructose, but are maybe 2 or 3 glucose molecules stuck together, things like what you see in bread, starches. So here we have the American Diabetes Association advocating that you eat a lot of starches, and then they want you to take an alpha-glucosidase inhibitor to stop you from digesting the starches because they know the starches are going to raise your blood sugar. It's sort of crazy. Their favorite starch is whole grain breads, but they also have fruits in there, and the alpha-glucosidase inhibitors will reduce the adverse effects on blood sugar of eating these foods. Will not eliminate it, will not greatly eliminate it, but will somewhat reduce these effects. The only adverse effect of the alpha-glucosidase inhibitors stems from the fact that you end up with these simple polysaccharides getting into the lower intestines where bacteria can digest them, create methane and possibly other gases, and cause flatulence. And the only hazard of flatulence is if you happen to be standing near an open flame, you can experience what the Italians would call un'esplosione, come un colpo di cannone. So if you're using these alpha-glucosidase inhibitors, which make no sense to begin with, just stay away from an open flame. The next category I'll mention is thiazolidinediones. That's Actos and Avandia. For a while, there was a big scare about bladder cancer, which is a very rare condition, and so rare that with or without the thiazolidinediones, it was almost impossible to find. And eventually, the scare was removed, but people are still asking questions in my teleseminars about the hazards of bladder cancer. There ain't no hazards. Several studies have been unable to find any association. There are associations, mild associations with bone loss or bone fractures, and there's still a warning associated with congestive heart failure, which has, I believe, recently been retracted, but I am not retracting it fully, because both Avandia and Actos, but mostly Actos by far, foster fluid retention in the body. And if you already have congestive heart failure, your heart is too weak to pump a lot of fluid around your body, a lot of blood. So one of the treatments for CHF is a diuretic to make you pee away fluid. But Actos causes fluid retention. So it might be hazardous for people who already have congestive heart failure. I happen to be personally prejudiced against excess fluid retention, so I teach my patients who use Actos to check for edema or swelling in the legs. And we do this for a little test where you press on your tibia, looking for what's called pretibial edema. And this test is demonstrated in one of my videos. So if you go through the 100 or more videos that I have on YouTube and on Facebook, you can see my test for pretibial edema. So if I put someone on Actos, number one, I know in advance that they don't have congestive heart failure. I wouldn't use it on such people. And two, I don't want them to get swelling in their legs. My reason for prejudice against this swelling is that I was director of the wound care clinic at a major university hospital. I worked there for 27 years, and the most common wounds of the legs that we saw were venous stasis ulcers. And these are caused by fluid retention in the legs. And so that's why I'm prejudiced against fluid retention in the legs. In any event, you have to check for pretibial edema, and if you're taking Actos, and to a lesser degree if you're taking Avandia, your doctor should teach you how to check for pretibial edema. The next category is sulfonylurea drugs and glinides, which are similar to sulfonylurea. These are drugs that cause the body to make more insulin if it's capable of making insulin. Now, there are some problems with this. According to the ADA, which still classifies these as major treatment options, and cite as the only adverse effect possibility of hypoglycemia if you use them incorrectly. But there's another effect that they don't mention. Back in the 1970s, I guess, there was a major study of the sulfonylureas because they were the only agent we had, the only oral agent we had for treating type 2 diabetes. It was called the University Studies Group. And this study showed a very substantial increase in heart attacks amongst the people who took sulfonylureas. There was some question about the accuracy of the study, but the numbers seem to be pretty overwhelming. So certainly low carbohydrate diets would have been much more effective than the sulfonylureas, but people weren't going to try low carbohydrate diets then. They were worried about fats. So here we had the entire diabetes profession was switching to sulfonylureas because there was nothing else available. And since that time, there have been repeated studies of association with heart attacks done in a variety of countries over the years, and these don't get mentioned in the Cochrane study that's being quoted in the Journal of the American Medical Association this week. I don't understand it. These studies have been repeated, and sulfonylureas, and I assume because they're similar, the glinides are hazardous and should be avoided. So I stopped prescribing those things after I was in practice only a few years because of the hazards associated with them. Next on the list is the GLP-1 agonists, glucagon-like peptide 1 agonists, Byetta, Victoza, etc. I've discussed these at great length on my teleseminar and also on my Dr. Bernstein's Diabetes University videos, and they have very little effect directly upon blood sugar, but they can have considerable effect upon appetite. The major adverse effect is that they slow digestion, which could be good because if you're type 2 diabetic, your slow insulin production can cope with slow stomach emptying better than it can with rapid digestion. So you might say that slow stomach emptying is an advantage also, but they can cause constipation, maybe nausea, but these are rare, relatively rare and mild. However, there is a package insert warning about pancreatitis, and everyone is pretending that the pancreatitis is so rare that you can not worry about it. Well, I was worried about it. So when I put a patient on a GLP-1 agonist, I test them for pancreatitis. And how do I do that? The next time I draw bloods, I measure their pancreatic lipase and pancreatic amylase. And the more important one is the lipase. And what I found is, over the course of a year or so, 3 people developed elevations. 2 of those people developed symptoms. One of them developed very severe symptoms and was about to go to a gastroenterologist when I called her and told her to stop the product. And sure enough, her symptoms went away. And not only did she have severe GI distress, but her serum protein dropped dramatically. And this is characteristic of pancreatitis, where the injured pancreas is leaking protein into the abdominal cavity so that the total serum protein level drops off. So here, in 1 year, the handful of people I had put on these agents were, 3 of them got pancreatitis. So my warning is, yes, you can use GLP-1 agonists, Byetta, Victoza, amylin, Symlin, and so on, but the doctor should be testing the patient periodically for at least pancreatic lipase. And if you find any elevation of lipase, you have to stop the product right away. Don't even assume it's due to another cause. Stop the product and see what happens to the lipase level. Next is the DPP-4 antagonists. This is a class of drugs like Januvia, and there's a group of them that are similar. These drugs inhibit the enzyme that destroys GLP-1. And the product is relatively benign, but it has virtually no effect on blood sugar. Why the FDA approves something that has no effect on blood sugar, I don't know. However, there is some evidence that they foster beta cell recovery. And therefore, on my teleseminars, I was advocating the use of DPP-4 agonists to foster beta cell recovery. And then came some reports that they increased the incidence of heart failure. So I advised on my teleseminar, you better not do this. Don't use them. And I advised that a month ago. But lo and behold, we now have new studies that have come out that have relinquished the inhibition of the DPP-4 agonists on account of heart failure. They supposedly do not cause heart failure. So I now can recommend them again for helping to foster beta cell recovery in a newly diagnosed diabetic or in a borderline patient or a pre-diabetic patient. They can foster beta cell recovery. So DPP-4 agonists would be back on my book for that purpose. One thing I forgot to mention when I was talking about the GLP-1 agonists, their only purpose, as far as I'm concerned, is to curb appetite. And we've discussed that at length. They can be very effective, but for many people, they stop working after a few months. So it's not like they're an absolute answer to curbing appetite, but they may be effective. I also should point out that the GLP-1 agonists that are sold to take once a week are not focused on the time of the day when you're overeating, so they're less likely to adequately affect your appetite. You're getting their effect all day long, and you're going to be developing a tolerance much more rapidly. Another oral anti-diabetic agent is the class of agents called SGL2 inhibitors. These include Invokana, and are agents that cause you to release glucose into the urine at a relatively low blood sugar. So instead of the renal threshold for glucose being, let's say, 160 milligrams per deciliter, you may start peeing away glucose at a blood sugar of 130 or 120 or 110 milligrams per deciliter, thereby eliminating sugar from your bloodstream via the urine. According to the literature, the major potential adverse effect of this would be urinary tract infections. I have one or two patients who find this extremely effective, like it very much, but there is a catch. You have to drink a lot of fluid because you're going to be peeing away a lot of fluid. You also have to urinate a lot. And if you're not drinking a lot of fluid, you can get dehydrated. And on the few patients that I've used this for, I have seen signs in their blood tests like a high hematocrit, that is, high red blood cell concentration, indicates that you have too little water in your blood. Or we'll see abnormalities in serum sodium level. So it is possible to get potential problems if you get dehydrated, or even if you drink too much fluid, you could be peeing away a lot of sodium. So there are potential problems. The doctor should be ordering blood tests every few months for sodium chloride, hematocrit, just to make sure that things are running normal. And as I said, some of my patients have found these to be extremely valuable, and therefore I can't say I won't use them. I'm just very reluctant to use them because it means more work for me. I have to keep on top of those patients and retest their bloods periodically. And that's basically the story with that group of drugs. SGLT2 inhibitors. Last on the list is metformin, which, for wise reasons, the American Diabetes Association has selected as their #1 oral agent, the thing that you try first. And I agree with that, but there are two categories of side effects. First category is GI disturbance, diarrhea usually. And for that reason, it should be started slowly and started with the time-release version, not the rapid-acting version. And the time-release should be taken in the lowest possible dose, 500 milligrams, at the end of a meal to minimize the likelihood of diarrhea. And then if you don't get diarrhea, you can add to the dose, taking it at another time of the day. And you can eventually, if so desired, switch from the slow-release metformin to the rapid release if you want more rapid action before meals. The other side effect is inhibition of vitamin B12 absorption. Metformin has most of its effects in the intestines, and one of its adverse effects is the potential for inhibiting vitamin B12 absorption. And this should not be ignored. I have not seen this happen, but it's been repeatedly reported in the literature. And the articles that I read say that if you consume calcium at the time that you take the metformin pill, you will eliminate that side effect. Well, that doesn't mean that you take a Tums whenever you take a metformin tablet. It means that your doctor first checks your B12 levels before starting the metformin. And because serum B12 levels vary from day to day widely depending upon what you ate, you want to also look at homocysteine and methylmalonic acid levels because they go up when B12 is low. So you get a baseline, and then after a month on metformin, you see what happens to B12, homocysteine, methylmalonic acid, and you see whether things are changing. And if they are, then you tell the patient, take a Tums with each metformin tablet, and then you see what happens by measuring blood levels. As a matter of routine, once I've got a person rolling on metformin without any adverse B12 absorption effects, I'll recheck maybe these 3 tests in 6 months or a year, and I'll do it again in another year or so, just to make sure B12 absorption is not being impaired. And one other warning is that we found that the generic metformin is much less effective on blood sugar than the brand name glucophage. And I've repeated that over and over in my various communications.